This presentation is going to be about fluid volume deficit, which is also called hypovolemia and dehydration. Don't you love how in nursing there's so many terms for the same thing? So this refers to a lack of fluid. There's a lack of fluid in the body. Either the body is not taking in, the patient is not taking in enough fluid, or there is an excessive loss of fluid. So some of the risk factors for fluid volume deficit or dehydration, hypovolemia, are older adults are more at risk because they have a decreased thirst reflex. In other words, they can't tell that they're becoming dehydrated. That reflex that makes us thirsty doesn't work anymore. They also have a decreased ability, decreased function of the kidney, so they can no longer concentrate urine like they used to. So they lose a lot of water in their urine. They also have lower amounts of muscle mass, and muscle mass holds a lot of volume, fluid volume. So those are the reasons older adults are at risk. Anybody with a prolonged fever is going to be at risk. When you have a fever, you start breathing harder or deeper, I should say, and you're blowing off fluid when you breathe, right? We lose like about 1,000 mLs of fluid daily just due to respirations, okay? The 3Ds, diarrhea, diuresis, and diaphoresis. So people on like diuretics, out in the hot sun on diuretics. People diaphoresing, so people like athletes out in the hot sun in the middle of the day. People that are NPO, but people that are NPO who have insufficient intake because they can't. Like think about the stroke patient who may not be able to swallow like they used to, or may not be able to function so that they can get water themselves or drink by themselves. Okay, so think of that. People in comas that can't take in PO fluid by themselves. A bowel obstruction can lead to hypovolemia. People can sequester up to 5 liters of fluid in their bowel if they have a bowel obstruction, so that could cause hypovolemic shock. Hemorrhaging, so people that are having procedures, surgery, they're going to be at risk, okay, for fluid volume deficit. The labs you're going to see are high, so you're going to have a high hematocrit, and this is due to hemoconcentration. So if you're losing fluid in your veins, the cells are going to hemoconcentrate, meaning it's going to look like there's more cells in the blood, okay? High specific gravity in the urine. I always have a saying, the higher, the drier. High sodium levels, also due to hemoconcentration of the blood, okay? Now, the findings you're going to see in a patient with hypovolemia or dehydration is they will have flat neck veins. Okay, so you'll see them there. You won't see bulging veins on their neck like you would somebody with fluid volume excess. You can use the mnemonic, dehydration to remember the signs and symptoms of fluid volume deficit. So D stands for dry mucous membranes, a furrowed tongue. People get furrowed tongues. They also get pale mucous membranes. The earliest sign of hypovolemia or dehydration is tachycardia. They will have a thready pulse. So that means a weak pulse, okay? The pulse will be weak. They'll have tachypnea, so that's breathing fast. They'll be breathing fast. They'll have hypotension, especially orthostatic hypotension with dizziness. So you have to worry about falls and keep people safe. The young will have a sunken fontanelle. Now, you haven't had maternal child, but I'm guessing you may call it a soft spot if you've never had anatomy before. So their soft spot will be bulging in their head. Don't worry about that. You don't need to worry about that until you are in your mother-child class. Decreased skin turgor. Now, this is not accurate on older adults, so you're not going to do or I should say, you're not going to assess skin turgor on older adults. So you're going to look for the other signs and symptoms like tachycardia, dry mucous membranes, weight loss, dizziness, hypotension, those kind of things, okay? R is for refill. So that means sluggish capillary refill. So capillary refill greater than 3 seconds. A is for attitude change, which really means they can become confused, fatigued, and very weak. Okay. T is for thirst. That's usually the first central nervous system symptom you will see before confusion, actually. So E is for experience weight loss or eyes sunken and elevated temperature. People who are dehydrated are going to have an elevated temperature. D is for diagnostics. So they'll have a low urine output with high specific gravity. And also, I already talked about high hematocrit due to hemoconcentration and high specific gravity and high sodium. All right, so let's analyze the cues. Like, what could happen to my patient if they become dehydrated? Okay, so they could develop hypovolemic shock. I was trying to put these in a good order, and um, they could die for hypovolemic shock. So I put that first. They're going to have cool, clammy skin, in addition to a lot of the signs I already mentioned. What we want to do is replace fluids. So they're going to need 2 large bore IVs, and we're replacing a lot of fluids. And for older adults, you have to watch them very closely and be very careful replacing fluids. They may need blood. We're going to put them flat in the bed with the legs elevated, because if somebody has shock, they're going to have tachycardia, tachypnea, and a low blood pressure. We never want to put the head of the bed up if somebody has a very low blood pressure, okay? Acute kidney injury can happen if the kidneys aren't perfused. So in cases where there's dehydration, this could result in an acute kidney injury, and you would see a low urine output, meaning a urine output less than 30 mLs per hour. People that are dehydrated can develop deep vein thrombosis. So you're looking for a warm red calf that is dematous and pain. And you would want, anybody dehydrated, obviously, to wear SCDs so that doesn't happen. Falls. So if they're orthostatic, they're going to be at risk for falling. So you know what to do. Keep the bed in the low position. Give them the call bell. Monitor their gait stability. In other words, make sure they can walk without swaying. The provider may do a Romberg test, which is a neurological test, which tests for balance. So there's a lot of variations on how you do it, but basically they're going to have stand up in bare feet, and they're either going to put their hands down by their arms down by their side or out to the front, or they may cross their arms. But what the provider's looking for is for them to stand still. If they start swaying, that's a positive Romberg test, and their balance is off. Okay, I'll just leave it at that. But you need to know that test. Okay, so prioritizing the hypothesis, hypovolemic shock can kill them, so you would want to definitely prevent that. Acute kidney injury, so 10% of the people that get an acute injury end up with chronic renal failure, and we don't want that for anybody. DVTs is another possibility, and falls. So we're going to prevent all these things with the interventions I just talked about. Let's talk about generate some solutions, like what kind of things can we do? What kind of interventions can we introduce that is going to help our patient and take action? So you're going to insert a 20 gauge IV, possibly 2 20 gauge IVs, depending on how critical the patient is. They're going to need IV fluid bolus. Now, a fluid bolus means you're going to give, an amount of fluid over a relatively fast time. So like an example would be give 500 mLs over an hour, over 30 minutes. It depends. You got to be very careful with older adults. Push PO fluids as tolerated. That means you're going to encourage people to drink if they can, if they're not NPO. Monitor the vital signs, because you're looking for like the tachycardia, with the thready pulse, and also hypotension. Check for orthostatic hypotension. Assess their mentation. That means like their attitude. All right. Do they have feelings of impending doom, or are they relatively happy? Are they alert and oriented? Because patients can become very confused if they have low perfusion to the brain. Check the pulse amplitude. I had mentioned they're going to have weak, thready pulses. So we would rate that as +1 pulse, and then A good pulse amplitude is +2 or higher. That means like the strength of the pulse. Okay. Encourage the patient to change positions in bed. We don't want anybody getting bed sores. We don't want them getting DVT, so we need them to move around. Instruct to rise slowly because they may be dizzy from orthostatic hypotension. Monitor weight during fluid resuscitation. Fluid resuscitation means you're giving fluid boluses, you're putting back fluid into the body. Monitor the urinary output. And if the urinary output gets really large, of course, monitor the potassium because potassium is excreted in the urine. All right, let's evaluate our outcomes. If we do everything right, our patient's going to be A&O times 3, or they're going to return to their baseline neurological status. Vital signs will return to baseline. The urine output is going to be 30 mLs or greater per hour. Dizziness will resolve. The patient will have nice, moist, pink, red mucous membranes. Skin will be pink, not pale. The capillary refill will be less than 3 seconds. Skin will be warm and dry and not clammy. The BUN in creatinine will return to baseline. The BUN in dehydration is greater than 25, and that's due to hemo concentration as well. We want to see improved skin turgor. And remember, we don't measure that in older adults, but that's, we want them to return to their baseline status. All right, that's it for fluid volume deficit.